the first 25-ish minutes, I'm gonna just be talking to give you guys some background, and then we're gonna go do some more active stuff. So I'm gonna try to, we kind of need to go through this stuff just so that you kind of are all starting on the same page, but I just don't want to spend too long on it. So we're gonna talk about kettlebells and rehabilitation. And this was such a big topic that I had to break it down even further than that because we could be here all weekend talking about this. So I'm going to be talking about kettlebells in shoulder rehabilitation specifically. I'm Ann Wendel. I'm a physical therapist and a certified athletic trainer. I live in Alexandria, Virginia, and I'm on the advisory board of Girls Gone Strong. So I'm happy to be here with you guys. I used to always put my contact information at the end of a presentation, and so now I've started putting it at the beginning. So if you're on Twitter, I'm at PranaPT on Twitter. I also have a business Facebook page that's Prana Physical Therapy, if you want to find that, and that's my family. So we're going to talk about the shoulder. I don't know why that's not all coming up. The shoulder is a joint that needs to have a lot of mobility, a lot of movement, and also stability, okay? And you can think about that kind of like a golf ball on a golf tee, if you're thinking about the ball and socket joint at the shoulder. It needs to have a lot of movement. And so we're not going to see pictures of my patients because I can't take pictures of my patients for privacy reasons, so you're going to be bored by looking at a lot of pictures of me doing stupid stuff. But so, I mean, even in a position where you're using the shoulder joint to climb, and so you're going through a lot of range of motion, a lot of mobility, you can see the muscles firing to give you stability, okay? We're going to go through this super fast, but just so that everybody has a basic understanding, the anatomy of the shoulder, when we think about the shoulder, the ball and socket, it's not just a shoulder joint though, it's actually a shoulder complex. So we've got the sternoclavicular joint, the acromioclavicular joint, the scapulothoracic joint. So there's a lot going on there, and we're not going to spend much time on all that. But the main muscles that people are aware of are the rotator cuff muscles. And so there are 4 muscles. One of these is probably pointer. I don't know which one. So at the top, you can see the supraspinatus. This is looking at you from the back over here. So the supraspinatus at the top, infraspinatus underneath that, the teres minor right under that, and then the subscapularis is on the front side of the shoulder blade, between the shoulder blade and the ribs, okay? You can see down in this area, in this small picture there, that's the capsule and the labrum. The labrum is cartilage, kind of like a ring that deepens the articulation between the ball and the socket. It's a really shallow articulation. We don't want to dislocate every time we move our arm. So that's the labrum. We have static and dynamic stabilizers in the shoulder. So the static stabilizers are things like the labrum, the joint capsule, and then all of the ligaments around the shoulder. And then the dynamic stabilizers are more of the rotator cuff and all of the muscles around the shoulder. Has anyone heard of the term centration before? It's a term that, yes, the engineer. So that's a term that's been made popular in the past couple years. And basically what that means is that the ball is going to be in the center of the socket. So the joint has an ideal position with the ball in the center of the socket. That's where we want it. And that's a dynamic neuromuscular strategy. So it's not like it gets there once and it stays there. As we move, it has to adapt, and we have to have the right neuromuscular strategy to keep it there. But it allows for the most effective mechanical advantage because muscles have a certain length tension ratio. Remember, like anatomy, physiology, and it allows for optimal load transference across the joint, okay? And then the last thing, actually, decentration. So if your ball is not sitting in your socket right in the center, it's going to lead to other issues. It's going to lead to an increase in tone in other areas of the body because the brain's like, hey, something's going on down here, and we need to get this in the right place. So you're going to start gripping with other muscles to try to make that happen. So I'm going to narrow this down even more from the shoulder. We're going to talk about a case study. One of my patients, she became a good friend of mine and was referred to me by her personal trainer, which is always a good thing. So this was back in March of 2013. She's a 46-year-old female. And this is kind of like, I don't know if you guys work with a lot of physical therapists, if you're trainers or anything, but this is kind of like what we do when someone comes in and we take their history and do their physical exam. And I just thought it would be kind of cool. I just kind of copied this right from her notes. 46-year-old female presenting to physical therapy with chronic right shoulder pain and new onset of right wrist and thumb pain. She had chronic shoulder pain off and on since high school from playing tennis, and she was very active, but she just recently began a personal training and boot camp style class, so she added that in, and she experienced a flare-up of the pain that she had before in her shoulder. In addition to boot camp, she was playing tennis 3 times a week, so she's very active. She had a child, and she was kind of in that, I want to work out, I want to lose weight, and all that kind of stuff. And so she was working out a lot. She reports that she had quit smoking 3 years before this, which is important because we know that smoking can change our ability to heal and things like that, tissue regeneration. But before that, she was a lifelong 1-pack-a-day smoker. Current function, she had right shoulder pain, especially with overhead activities, hand behind the back activities, push-ups, tennis. She had that right thumb pain, carpal metacarpal joint pain with weight bearing, so push-ups and burpees and things like that, and pain with squeezing and gripping and holding the tennis racket. So again, from her medical history, we know she was a smoker. That's going to affect her tissues and her healing. She had a vaginal delivery with her daughter, and if you were here last year, you heard me talk about pelvic floor dysfunction and why we need to think about that for everything, not just low back and pelvic injuries, but it affects your shoulder too because it changes the stability and the tone throughout your body. No one had ever asked her this before, but she had stress incontinence with coughing, sneezing, and jumping. So here she's a pretty high-level athlete. She's having shoulder pain. No one's ever asked her any of these questions. So these are things you guys can ask your clients and at least direct them to the right person. And she had seen an orthopedic surgeon, and surgery was recommended for her shoulder for the issues that she was having. Her MRI was positive for a supraspinatus tendinosis, so that's the muscle at the top of the shoulder that we looked at. She had a partial tear of the biceps tendon, and the part that was intact was subluxing out of the groove that it's supposed to be in. So she was kind of hanging on by a thread, literally there. She had a tear of the subscapularis and old labral tears. So her labral tears were in the back here. The labrum, again, is one of our static stabilizers. So she has tears and problems with not only her dynamic stabilizers, her muscles, but also the static stabilizers. And her goal was to exercise without pain. She really wanted to get back to tennis. That was really her goal. So this is not my patient, but this is to remind me to tell you guys that we always need to look at alignment, and there's no one perfect posture, but when we see something that looks like this, we have to think about what that's doing and where it's putting the rest of the body, okay? So when I looked at her, she had decreased upper thoracic spine extension, so she was a little bit rounded. She was tender to palpation over her long head of the biceps tendon, which makes sense given her MRI. She was tender over the insertion of the supraspinatus tendon, positive test for rotator cuff pain, limited by pain, and decreased strength of her mid and lower traps and her serratus anterior. So we know that even her dynamic stabilizers that are intact are not as strong and not functioning as well as they need to be. But her goal was to play tennis. That's also not my patient. That's Serena Williams, who's a total badass. So the plan of care, what I set out that we needed to work on, involved things like mobilizations of the joints, trying to get her a little bit more upper thoracic spine extension, stabilization, strengthening motor control here. This is also not her, this is somebody else. But I also do dry needling in my practice, so that's one of the things that I use for pain and muscle spasm and things like that. So we did all of that. In 10 visits, she came in and said that she had a lot more pain in the last few days. She had played tennis 3 times in the past week, and she played a lot of ping pong over the weekend. What I didn't put in her note was that she had consumed large quantities of alcohol and played a lot of ping pong. And so she wasn't really paying attention, and she was out all day, and she was doing all this stuff, and so she was just flared up. So I just had to take a couple of days off, use some ice, avoid overhead activities. Let's see how you are next visit. Let's just kind of keep going with this. She came in on the 11th visit, was doing much better. She could now do push-ups. She hadn't been playing tennis, so the shoulder wasn't terribly painful, but again, that was her goal. And so she had a resolution of the majority of her symptoms. She could sleep, she could do her activities of daily living, but she continued to have pain in the long head of the biceps tendon. And she was going to go get a second opinion on the surgery. And what I wanted to say back on the slide on the centration that I forgot, if the joint is not staying in the center and the stabilizers like the rotator cuff and the labrum are not holding it there, and we don't have the right neuromuscular strategy, quite often what happens is that the ball starts to translate forward in the socket, right? So what's in the front of the shoulder that's going to stop it? Long head of the biceps tendon, right? So she's constantly flared up, and if you were only to treat the pain in the long head of the biceps tendon, you're not really getting anywhere. You always have to ask why. Why does that hurt? Well, she's got a shoulder that can't stay where it needs to, and the biceps is trying to dynamically stabilize it. Okay. So she ended up going and having surgery. This is not her, but that's how she felt after the surgery, because we had gotten her to the point where she could do pretty much everything she wanted to do, and now she was starting over. And so for those of you who work with clients who have had surgery, it's a really difficult time, not just physically, but also mentally. She would come in crying, and now she couldn't sleep again, and things like that. So we need to be aware of all those things. So in August of 2013, she had surgery. What was done was a biceps tenodesis. So they basically took her biceps tendon, detached the part that was still intact, drilled a hole through the humerus, and put what they call a button on the other side. So they basically gave it a new insertion so that it was not still in that same degenerated, painful spot. They repaired her supraspinatus tendon, debrided the labrum, so the cartilage in the joint, the labrum, the static stabilizers. And so debridement of the labrum is actually a much faster recovery. I don't know if any of you have ever worked with women who have had a labral repair. It's much more involved. You have to be immobilized for a much longer time. But when they debride it, they just go in and kind of shave out the pieces that are torn. And they also took out bone spurs. So when we look at the rehab when she was coming in, kind of break it down into 4-week segments. And the early postoperative phase is not terribly exciting. They're in a lot of pain. You're just trying to minimize pain, getting passive range of motion going. So where she's laying down and I'm moving her arm through the range of motion. It's starting to get some scapular stabilization, so maybe some scap squeezes and things like that. Shrugs, kind of boring. Second phase, they can finally get out of the sling at about 4 weeks post-op. Still not doing a lot of active movement until 6 weeks post-op for most people. This is generalized. This was her surgeon's protocol that I discussed with him. So you're focusing on the scapular rotators, maybe doing some internal and external rotation work and things like that. Having her on her side and doing some side-lying abduction, because we all know when people have a weak shoulder and you have them do it standing up, they're going to do that, which then they're like, why does my upper trap hurt all the time? And so no resistance exercises except gravity and very light tubing for 12 weeks. When you're an athlete and you can't do anything for 12 weeks, that is really hard. So I try to make that as fun as I can, I guess, with my patients. So with her, between weeks 4 and 12, we began some quadruped weight bearing, so having her on hands and knees, doing some shifting forward and back, side to side, a little bit of crawling. She's able to bike and walk, doing some stuff with TheraBands, foam roller for thoracic spine extension. These are all of the things that are leading up to her being able to do kettlebells, which is what we're going to talk about in the second part. But if we don't get that upper thoracic spine extending and then we have her do a press from here, that's not great. So we just had all that stuff taken care of in the shoulder and we're going to put her back in that same position. And just for like a benchmark kind of a thing, at visit 14, she still doesn't have enough range of motion to fasten her bra behind the back. So I mean, I don't really wear a bra, so that's not a problem for me, but for a lot of women, that's a big deal. And so that's a big kind of landmark in their recovery is when they can actually get the bra fastened behind the back again. At visit 18, we were able to add in Turkish get-ups with weights. So she was someone who had been trained in that motor pattern. She had been working out with her trainer, and we were able to finally start doing that. But that's 18 visits. That's 10, 12 weeks into her rehab. So it can be very frustrating for people. And then weeks 12 plus, just really going, and when you see a lot of physical therapists, this drives me crazy. They still have their patients there doing TheraBand, 12, 14 weeks post-surgery. And like, come on, we got to do better than that. So I try to build in stuff with kettlebells as soon as I can. So at week 12, she's entering the strengthening phase. And when my patients finally find out they can strengthen, they want to go do all the stupid things. So this is my friend Cliff Harsky doing a Turkish get-up with me, and Cliff has a great saying, don't work out like an asshole. So when your patients or your clients can finally go back to the gym, you don't want them doing all the stupid stuff. So Turkish get up, why is that good for people who have had shoulder surgery? You get stability for both glenohumeral joints. So the down arm, is everyone here familiar with a Turkish get up, or at least kind of what it looks like? Okay, we're gonna work on it later. The arm that's down on the floor is getting a lot of joint proprioception, there's a lot going on there in the neuromuscular system. The arm that's up, especially if it has a weight, is also getting that joint compression and that idea of where the center of the joint is again. You're getting scapulothoracic stabilization, so you can't be on the ground and like this and feeling good and looking good. You've got to get up out of that shoulder joint. You've got to have the arm back and up in the air. So it works on all of that. It incorporates the deep central stability system. So like we talked about pelvic floor dysfunction last year, kind of building in that breathing and the pelvic floor, the deep abdominals. People have been in a sling for sometimes 4 weeks, 6 weeks. They haven't been breathing very deeply. They've been in this protective mode. So all of that is important to get going again. And the Turkish get up encourages trunk rotation. So again, if you've been in a sling like this for a couple weeks and then you haven't been able to move your arm very much, your thoracic spine is stiff, not just in extension, but also in rotation. So this is a great exercise to work on all of that. The windmill is another one that we're going to go over today. Again, it encourages overhead stability, so obviously you would have them start with maybe using a shoe on their hand, which we're going to do today, which is how you teach the kettlebell stuff initially. Building up to using a weight, so maybe she can't use a heavy weight in the beginning, but even just getting down into that position is good. You're training the neuromuscular system, you're incorporating the hip hinge, right? So it's not just a bend over, we're getting back, especially with your athletes, getting into those functional positions, training the hip hinge. You're getting the thoracic spine rotation, the breathing, the deep central stability system, your pelvic floor. And we're gonna cover different variations of all this stuff. So if you've ever tried a bottoms up windmill, has anyone ever tried that? Super hard, and you can go really light with it, but trying to keep it in that bottoms up position will humble you very fast. It's what?
You need a helmet.
A helmet, yeah. But the good thing is that, initially after surgery, you can't lift really heavy. So you have to kind of think with your clients, well, they're limited to lifting 5 pounds or 10 pounds. That's a way to make something a little bit more difficult and challenging for their neuromuscular system. Put them in a bottoms up kettlebell exercise, okay? And then the press, here's me in press in a dress. Don't ask me why I took that picture, but it seemed like a good idea at the time. Doesn't everything? So encouraging stability overhead, especially with a bottoms up press. So if you've ever done bottoms up press variations, we're gonna cover those today too. Adding in strength. Carries in the bottoms up position. So again, if you can't go heavy and you have to stay light, I like getting my clients to kind of pick up the kettlebell in the bottoms up position, 90-90 at the shoulder and the elbow, and have them walk with it. That's super hard. So they're getting a lot of, when we talk about shoulder stabilization, that's shoulder stabilization, more so than standing there with the TheraBands doing this, right? It's more functional. And we're not going to cover these today, but I just put in a couple extra ones. So carries, farmer carries, you're teaching a packed shoulder position. We're going to go through that again today. It's very functional, so think about your ladies or your guys who they're picking up heavy stuff, they're picking up groceries. You just had this really expensive, painful shoulder surgery. You're going to go down and pick up your groceries like this with your shoulder just dangling? No, you need to get in a nice packed position, teach them how to do that. A lot of women who haven't been active and haven't been trained how to do these things need those motor patterns. Crawling, again, I love crawling. It's great for proprioceptive feedback to the joint. You got the upper extremity weight bearing. Think about all the stuff we do that's weight bearing for our lower extremity. How much do we do with our upper extremity? Push-ups, I mean, in a daily life, most people don't do much upper extremity weight bearing, so put them in crawling. Here I'm doing backwards crawling, so knees up off the ground, backwards crawling, dragging the kettlebell. Again, another very humbling thing to do. But you don't need a heavy weight, and you can even just do it body weight. And then this is my slash pipe. My husband's very handy. I had him, does anybody have a slash pipe at your gym? And it's awesome, right? So that requires, so basically it's a PVC pipe that you put caps on the end and you can put as much or as little water in there as you want. but you get that thing up overhead and it's doing this, that's shoulder stabilization, that's core stabilization, right? So that's just, it's new stuff that you can add in for people to do. So we're going to do in the hands-on portion the Turkish get-up. We're going to break that down so that you can kind of feel each thing. And you're not going to be an expert in 30 minutes or whatever that we have, and you won't be able to coach it if you haven't done it before. But I want you guys to see how it can be used with your clients who maybe can't do the whole thing, and then the press and the windmill. And then, are there any questions before we move to the hands-on? Yeah.
So you go from body weight to what is the next step? Like, do you give them just the little baby kettlebell, or do you give them like maybe a Theraball, like something that's weighted but not as
for like a press or
unstable?
something like that? I mean, so that it's always dependent on the person and where they are and all that kind of stuff. But yeah, I mean, I tend to go, if you guys don't have light kettlebells, get some. Like, I have a little 7-pounder, which is what I started doing. I was like, God, this is heavy, doing my swings, right? But yeah, start small. You don't have to even have kettlebells. I mean, you can do this with a dumbbell. You can have them do, presses. Even like holding the dumbbell upright and walking that way, or overhead stabilization with the dumbbell, you can do that. So, that stuff's fine.
Obviously, you want to have nice, stable shoulders, especially if you're starting from the beginning or starting over from an injury. So the first thing that we normally do, go ahead and give me this arm. Okay, so just to see, this shoulder is not packed, this is loose, right? So it's going to come out of the socket. So what you want to think about, how you guys saw when I was doing push-ups yesterday about corkscrewing the shoulder. So she's going to take this shoulder, she's going to corkscrew it, and it acts as if she's like putting it in her back pocket. Okay? Now it's going to be nice and tight when you have this arm. Keep that shoulder in the pocket. Okay? Nice. All this nice and tight. See the difference? Okay. So your body should be able to move as one unit. So we're not reaching for the sky and disconnecting, so you can keep that nice and tight. So really quick, just to get that feeling, try it with the person next to you, and then we'll break down the get-up.
And again, this is like the carrying the groceries idea. Don't pick it up with the shoulders just hanging there. So try it like unpacked first, and then try it in the packed position so you can feel the difference. Sure.
Like it's like a massage.
Switch. If you haven't switched, go ahead and switch. Good.
Okay, so the reason for the shoe is going to become your weight. You're going to balance it. When you're in this position, you're going to balance it on your fist. Keep your shoulder back, okay? So if you do the get up properly, you should be able to start on the ground. And your thumb has to be tucked. You can't do this and cheat. See this thumb right here? Okay. This is where everyone should start. Even if they're not going through physical therapy or rehabbing shoulder, this is really a great place for people to start. But you should be able to do the whole movement. Without the shoe falling. But don't worry, you're not going to go that fast. I'm going to break it all down for you. Okay. The reason for that is it sets in muscle memory, because in kettlebells we have no wrist. If you have a wrist bend, then your elbow can bend. And I have seen someone do a get up with a heavy bell, let the wrist bend, then the elbow bent, and it came across their body. Natural tendency was to catch it here, which broke their wrist. Okay. In class, everyone heard it. So I'm going to show you the safe way. Okay. So everybody on your back.
And this is good too if you train kids, teenagers that can't lift a lot of heavy weights, things like that. You're training their motor patterns.
Okay, so your shoe's on the right. Bring your right leg up and plant it on the ground. So plant that foot with a bent knee. The opposite arm, remember how I mentioned like doing snow angel to make sure you have space. So you're going to do the opposite arm, opposite leg out at about 45 degrees. Okay. From there, you're going to lead with your chest. So it's a little bit of a roll to the side. It's if you were going to roll this way. Okay? It's not a crunch. So come to the side and go up onto your forearm. Okay? When you're in this position, we should not be lounging on the down shoulder. So we're not just kind of hanging out, resting on that shoulder. Think about packing both shoulders and making an X on your back. Okay? From there, you're going to go up onto your palm. Okay? Now, one thing that I like to do here, and this is not a requirement, but it really helps you know where your mobility is at, and it's great for instructors to look and see if you have proper shoulder and T-spine mobility, is see if you can set your opposite butt cheek on the ground and still keep your arm locked out. When you sit nice and tall. Okay? So we can look at a get-up as an assessment and see what's going on with your body. Then from here, this is normally where most people get stumped. So from that tall sit position, I'm going to break down the swoop in 2 steps. So the first one is, think about the straight leg. Your heel is coming towards your toe. And then you're going to lift slightly and bring that knee back to your hand.
Beautiful. You guys look so good.
Okay. Normally, that's not what you see. Normally, you see people going, how am I getting this leg through here? Okay. So heel towards toe, knee towards hand. Once you're there, you're going to think about hinging. Okay. If we're here on the ground, you're going to hinge your hips and sit up. Finish. So it's just like a swing, right? You hinge, you finish the move. Same thing in a get up. So hinge, finish, and then go into your half kneeling stance. Your toes should be tucked in the back. That way you're going to push off the ground.
So
when you're in
swinging.
half kneeling, this is when you stop looking at your bell. Every other time you're on your bell except for half kneeling and standing, go ahead and stand up. Good. Big step back. Keep this arm nice and tight, should not be bending. Windshield wipe the back leg. Hinge again at the hips, find the ground. Kick the leg back through. Back to your elbow. And all the way back down. Okay? Pull it down, switch sides. And then if you want me to run up to the other side and then you just talk about.
Yeah, and we'll stop at each stage.
step?
And I can like say something.
Okay, so we're gonna do the other side, but we're gonna make it slower so that she can give you pointers for for this presentation, okay? So opposite side, knees bent, arm and leg are straight on the right side, okay? Driving from the chest.
Wait, let's stop right there real
Right
quick.
there? Okay.
So in this position, if you have a kettlebell or a weight in the hand, this becomes an exercise or a rehab exercise, whatever, corrective exercise on its own. So if you're holding the kettlebell and it's an offset weight, I have patients sometimes do this as what we start with. They're not even moving the arm. It's just staying there. And I have a video, I just didn't put it in the presentation, but one of my patients who's pretty strong, his arm was just shaking, okay? So this might be enough right there, and maybe that's where you start. Okay.
Good. Now, the great thing with the get up is that you can break it down like this. Even if you're not doing rehab, okay? You find your sticking point, or maybe you've been doing get ups and now you're ready to go to a heavier weight. Break it down. Find the step that is where you're at right now. Pattern that portion before you go on to the next. Okay? Drive with the elbow, lead with the chest, come up onto your forearm.
So again, here, right, we've got the weight bearing through the arm that's down. If you have a weight, you've got weight bearing through the arm that's up. You're open through the chest. You're getting some rotation. It's all good. All good stuff.
Okay, up to your palm. Okay, you're still watching your bell or your shoe. Your arm is straight. It should be vertical. Okay, I'm going to use this one as an example. You are vertical, but if she was not, the shoe can still kind of stay there, but with a heavy weight, it's going to keep going. Okay, so just make sure that you're really focusing on that, and then bringing this knee out. Okay, now you're going to bring your heel towards your toe, stabilize and lift, and then bring your knee back to your hand. All the way back. Open those hips up. Good.
Keep your leg, back leg.
Yeah, turn.
Yeah, there you go. Still in the windshield wiper.
Actually, right in here. There you go. Should be like the natural bend of the hips when you guys get the leg in the right position. So look up here really quick. Sorry. When you guys are in that windshield position, this should be one straight line. Your heel, your knee, and your hand, this is where you're most stable. If you're back here trying to stabilize, everything's going to be a little less safe. So nice and tight. Okay? Hinge into the hip. Finish with the hip. Half kneeling.
So straighten out your back leg, yeah, and windshield wiper it, yep.
Up on your toe. Looking forward, nice neutral spine. Stand up. Elbows are nice and straight. Big step back. Windshield wipe the leg. Now, quickest way to know that you're getting in the right position with your hand, rather than just reaching, because a lot of people are still reaching back here and then you're sitting on your leg, go ahead and tap your leg and swoop off. As you hinge, swoop to the ground. It'll give you that proper alignment. Swoop and kick through. Okay, you still sit tall. Back to your elbow. And all the way back down.
Nice. Good job.
I have a question. I have some clients that do this and what's a good cue? They say my neck, people that just normally have neck issues with body weight rows and tears and things like that or whatever. They don't want to do it because they feel it
tense
in
their neck.
And I'm
Okay,
like,
one is they may be trying to crunch, so they're tensing here. Okay. So what you can do is make sure that they pull their shoulders down and just get them rolling. Like tell them to load this glute when they're pushing off, so they're pushing through both feet and they're rolling this way. Then when they get here, have them do a neck check. Relax. We're here, neck check. So you just have them relax it. But it may just be if they're trying to crunch, like I see people all the time, they're like, oh, hey, these get-ups. Me too.
Because that's a pattern we know, right? We know the crunch pattern. Our brain knows to tell our nerves to tell our muscles to do that. Rolling is different. So you can even break it all the way back down to the rolling, which is,
rolling for a while.
yeah. And the other thing is they may not be breathing. So a lot of people, especially if they have a history of pain, like shoulder pain, neck pain, they're gonna hold their breath. They're probably shallow breathers, upper chest breathers. Those muscles are always on and they go to get up and they've got this going on. So teaching them how to, keep the head neutral, tuck the chin, like you said, roll the neck side to side. That it should be easy. What do you call it? Face something shield? Breath?
Breathing behind the shield.
Breathing behind the shield, right. So you don't want your get up to be like, what does Kelly Starrett say? Don't make the pain face, right?
Yeah.
Like, relax from here up.
Faces.
Breathing.
But you also don't have to teach the whole thing. Like it's very rare if I have beginners that I teach them the full get up. We just may pattern this. Breathe. Elbow to pump. Elbow to pump. Back down. Or just the swoop through. So you can just break down every portion. But the stabilizing in the shoulders with no weight is really important in the beginning, which I think we have discussed, is just being able to post. And so right now I have a guy that I'm working with, he just got cleared from PT, and we're trying to build his stability back and his strength. And he's back to like an 18-pound belt, and we're just getting him to here. Because he can't fully go overhead just yet, his mobility's not back yet. So we're getting him into the get up just this position, and then we're slowly working on what he can do here. So he doesn't do full get ups yet. But it really is a great exercise or lift as you get stronger.
So I'm not a trainer, I'm a programmer, so I sit at a desk all day like that, and that's the first time I've ever done these. And I noticed I was really struggling keeping my shoulder packed. So do you think it would be beneficial to train this with just my shoe until I can get to a point where I'm like,
Yes.
like a baby? Okay.
Did everyone hear her question? She sits at a computer like this all day, and so it was hard for her to even maintain. See that a lot with your clients if they've had an injury or surgery. Those muscles fatigue really quickly, especially if they didn't have good motor patterns before. So scap squeezes, like I tell all of my patients, you should never sit longer than 30 minutes. Not never, but every 30 minutes you need to get up, do some scap squeezes, do some, whatever, move the head, and then sit back down. It doesn't have to be a 10-minute break, but you've got to get up out of that position and change it. And when you sit back down, you're going to be in a slightly different position because you're not going to go back to that same exact, you'll be in a different position, like maybe not the best one, but there's no perfect posture. We just can't stay in the same posture all the time. And when you're not taking those breaks, you're getting fatigue, you're getting weakness of the muscles that need to bring that back. So even just building in like some scap squeezes every 30 minutes or something, and then your brain's like, oh, right, that's where the shoulder's supposed to be. That's where the ball is supposed to feel in the socket,
And then you can also, if you're here, what's going to happen is your pecs, they're going to shorten, so you can stretch your pecs. So you just go in a doorway, go about 90 degrees with your arm. So you're pressing against the doorway here, and then you just rotate, look over the shoulder, kind of stretch here. You'll feel it stretch. So that, and then, I don't know if you were in the one yesterday where I did T-spine, would be important for you as well, so that you can stabilize. Because if you're tight, you may be able to stabilize, but you're maybe not stabilizing in the angle that is necessary to have load overhead.
Which is important because if you progress, remember we talked about the mobility and the stability. So, you know, in rehab, we kind of do a delicate dance between those two. So we open the joint up a little bit, we get more mobility, but then you have to build stability in that new range of motion. So you're not gonna start loading people really fast with this stuff. Just because you can muscle through it doesn't mean you should. So you've got to build that foundational mobility and stability and then put the load on top of it. You don't want to put load on top of dysfunction. That's just crazy. That's how people get hurt.
Yes, absolutely.
Yep.
I know when I was doing it, I kept pointing my foot and my down leg, you know, to kind of, I guess, compensate and get some stability going. Do you have any cues of people to kind of stop that, or is it okay to kind of brace that? Or?
You can point, but what you'll find, especially when you go heavy, there's a couple of reasons on why you're doing certain things with your legs.
Yeah.
So for example, if your core is not strong enough and you're trying to do a heavy load, not only will this not maybe flex the way that you need it to, but it will also like jackknife, like you try to come up with your legs like this. Okay. So what I do is I would have you do your rep again. Okay. Press against me. Okay, go ahead and like come off the ground. Okay. Push, push against my foot. And now come up.
Oh, yeah.
Yeah, just force you to extend.
Yeah, definitely.
So and what she's doing is giving your nervous system input, right? She's telling your foot, okay, here's the ground, basically, because when your foot's up like that, you don't know where the ground is, your brain doesn't know what's going on. Here's the ground, then your body's able to get that stability through the whole nervous system, which is what weren't you talking about that yesterday with the kettlebells on the feet for the pull-ups?
Yes.
Yeah, so again,
yeah,
giving your
forces
body that tension.
That should later just become natural. Remember how I was talking about building tension is a skill just like anything else? Once you learn how to just naturally build that tension, you don't have to think about it anymore. It just comes natural so that you can focus on whatever else you're supposed to do.
Yeah. So we probably have like 5 more minutes. I'm thinking maybe we do the windmill because we talked a little bit about presses yesterday and kind of covered that. And if you guys have more questions, you can just grab me later. But windmill, sound good? Go through that. You want to show that?
Love the windmill, and it's most often done incorrect. So I'm glad we're going to do this.
Yeah.
Okay. It is actually a level 2 kettlebell skill. So go ahead and we'll just get into it. You can do this
You
with
show
your shoe
first.
as well.
Show first so
Okay.
you can see the whole
So a
thing.
lot of people feel that a windmill is just leaning and reaching the ground, and it's not about reaching the ground at all costs. Okay, it is more about the hinge and the T-spine rotation, and then the stability in the shoulder. So what you would do is you would press or snatch to get the belt overhead. You're going to take a fairly narrow stance. So if you start here from snatching or pressing the belt, you're going to rotate to the side. You're going to load that hip. So you're hinging out to the side. And then from here, I'm going to rotate, watch the bell, and watch through rotating of my T-spine. Okay? But normally what you see is the weight comes forward on this leg, and people do this. And everybody wants to take a picture of this, right? Because the angles are really pretty, so we want pictures like this. But this is wrong. So load the back leg. This leg should be soft. So visualize if you have an egg underneath your foot that you're not going to crack. So the load is in the back, and rotate. And if you only have a small amount of movement or rotation, that's fine. It's not about touching the ground. Okay? That's just a bonus if you have that mobility. Okay? So everyone stand up. And first, just to get you guys loading properly, so stand with your feet about shoulder width apart. We're going to rotate the feet to the side. Solid left leg, bent right leg. This one's soft. Push your hip back.
Get sexy with it, like get the butt
hip.
out there, get a sassy hip.
And if
What is
someone's
it,
not getting
tendon
that
stuff?
and feeling that, same thing, give them feedback. Press against my hand. Really hard, press, load your glute, feel the difference? Okay, so you should feel that load. So solid straight leg, because that's your base that's holding this bell over your head once you extend your arm. So lock this leg out. There you go. So it's solid, okay? Locked, hip, pushing here, and then you're gonna think about your shoulders coming across your body and hinging at the same time. Okay? And then we do that. You can find a different position, like if you need your foot to come a little more forward or a little more back. But the key is, it's just like you're hinging for a swing or a deadlift, but now you've turned your legs and you're hinging. But then lock this leg out. Okay? Put your shoe over head, hinge, and rotate. Okay? Locked out arm. That arm should be completely solid.
So the kettlebell is like kind of just corkscrewing in the air. It's not like moving, right? So
Yes.
it's literally going straight up and down. It's just that it's turning with, okay.
Yes, and that's why you want it stacked. So
Otherwise you would see that, you would notice that shift if you're seeing that kettlebell move with you. You
Yes.
would know that you're doing something wrong
Absolutely.
down here, right? Okay.
Just so you guys know, like all of this is a windmill, right? Like I used to do a lot of yoga and I had a great teacher who was like, you know, this is triangle and this is whatever, like whatever you're able to do and wherever you are, you honor that before you try to push yourself into the next position. So if all you can do is hold the weight overhead, that's where you start. If you can't do the weight and you just turn, and that's a whole lot of thoracic spine rotation for a lot of people, that's where you start, and it's okay. Don't force it.